Bismillah Rahman Rahim. Assalamu alaikum. Dear colleagues and dear PGs, previously we discussed chronic hepatitis B patients, when to start antiviral treatment and what type of antiviral treatment needs to be started in these patients. In today's discussion, we will see that after starting the patient on antiviral treatment, how we should monitor these patients on treatment to see whether the treatment is effective or not, and how we should proceed in the initial months and in the later on. So starting the discussion that chronic hepatitis B, how to monitor antiviral treatment. I already shared the slide with you that I recommend EASL guidelines for the treatment purpose and for the reference. These presentations, they are based on the EASL clinical guidelines. We did see that what's the difference between hepatitis B and hepatitis C. We know because hepatitis B is a nucleic disease, so it's only controllable, and antiviral treatment is not started in each and every patient. Rather, it is started when it is indicated, and once indicated, it's a lifelong antiviral treatment. Then we did come to know that the algorithm of starting any patient on antiviral treatment or not starting is that in the first step, we evaluate the liver status, then we see the viral load. In the third step, we evaluate the ALT levels, and in the fourth step, we look for the other factors. We discussed about the color coding. The red color is for cirrhotic liver and any detectable level of DNA, regardless of the ALT. The treatment needs to be started. In case of fibrotic liver, that is the yellow color. The DNA should be more than 2,000 and the ALT should be raised, any level, but it should be raised. Then it qualifies for the antiviral treatment. And in the case of normal liver, that is the green color, the DNA level should be more than 20,000, ALT should be at least 2 times normal, and then antiviral therapy will be started in such patients. And if the extended criteria is when the DNA fulfills the criteria, but the ALT is normal, in that case, according to the EASL guidelines, if the patient age is more than 30 years, if there is family history of HCC or cirrhosis, or if there are extrahepatic manifestations, then such patient needs to be started on antiviral treatment. And if, on the other hand, the DNA is a low-level viremia, in case of fibrotic liver or normal liver less than 2,000 units, then AASLD guideline suggests that to do the HbS antigen quantification. If it is more than 1,000, you need to start the patient on treatment. But if it is less than that, then you follow up these patients to see if they qualify for the antiviral treatment long term. And then we saw that there are 2 types of therapies, pegylated interferon and the oral drugs. In the oral drugs, entecavir, tenofovir, and tenofovir, either the TDF or TAV, they are the first-line treatment. If you haven't watched those videos, I'll share the links of these previous 2 videos in the description below, and you can see those so you can understand this video in detail. So we have started a patient on antiviral treatment. Now the question is how to monitor. We monitor these patients for 3 main aims. The first aim is to see whether our antiviral treatment is effective or not. By and large, the latest the current antiviral treatment, that is the entecavir or tenofovir, they are very, very effective, but still we need to do the on-treatment monitoring. For on-treatment monitoring is, number 1, that the liver function tests that includes the bilirubin, ALT, AST, alkaline phosphatase, the HBV DNA PCR, and if the patient is HBe antigen positive chronic hepatitis, then E antigen and anti-HBe. These are during the first year checked every 3 to 4 months. During first year, they check every 3 to 4 months, and later on, then every 6 to 12 months. We expect that after the end of the first year, the LFTs have become normal, the DNA PCR has become negative, and we expect and we hope that the E antigen seroconversion also happen. And after we get these parameters, then we check these parameters every 6 to 12 months, and it is the lifelong checking of these investigations. The HBS antigen every 12 months in patients with persistently undetectable HBV DNA. And if a patient who is in the second or third year of antiviral treatment and the DNA remains negative, ALT remains normal, and the E antigen remains undetectable, so then better to check the HBS antigen status at least annually to see if the patient is going to lose the HBS antigen or not. And those clearing HBS antigen should be treated, tested for anti-HBS then. So first you check for the HBS antigen by ELISA, and when it becomes negative or by MIA method, then you check for the anti-HBS. This is the on-treatment monitoring for the antiviral treatment. Second component of the antiviral treatment monitoring is for the antiviral treatment safety. We need to check the periodic renal monitoring in those treated with TTF and those at the risk of renal disease treated with any in fact. The elderly people are already those who are having the metabolic kidneys, like they are diabetic, they are hypertensive, or some other disease can affect their liver on the long-term NSAIDs. So these patients, in these patients, the periodic renal monitoring is very, very important. And what is the most important for this purpose? The serum creatinine every 3 months during first year, and then every 6 months. So the creatinine is checked for the renal safety of the entrecavir. And same if the patient is at the risk of osteoporosis, then periodic DEXA scanning of the bone must also be done. And the third monitoring is for the liver disease status. And this should include EPRI, FIB4, and FibroScan if available for the cirrhotic patients, or for the cirrhosis if the patient may not be cirrhotic and the patient PCR may have become negative, but later on the fibrosis can proceed, can progress, and if it progresses and enters into the cirrhotic level, then of course the cirrhotic surveillance protocols like for the viruses, for the HE, and for the ascites will be done. And you do the ultrasound alpha-fetoprotein for hepatocellular carcinoma surveilling. For a non-cirrhotic or fibrotic liver, you check less frequently, but for cirrhotics, you check more frequently. So these are the on-treatment monitoring under 3 headings: for antiviral treatment efficacy, and for the antiviral treatment safety, and for the liver disease status. And when they are done, this is you start the patient on antiviral treatment, and at the start you do check the ALT levels, the PCR, the E antigen, E antibody status, HBS antigen, and then every the first 3 months, then the second, say 6 months, 9 months, 12 months. During the first year, you check these ideally 3 monthly. The PCR, if the cost issue comes, then for the PCR, you can check every 6 months. If we don't check HBS antigen during the first year, by and large, we check this when the BPCR becomes a negative, E antigen seroconversion happens, then we check this HBS antigen. And once HBS antigen becomes negative, then we go for checking of the anti-HBS. And the response to antiviral treatment, it will be virological, it may be biochemical, it is serological and histological, and we shall discuss this in the next video. So, dear colleagues, this was some discussion about the on-treatment monitoring. You selected the patient to start antiviral treatment, you selected some antiviral agent, and then you started the patient on antiviral treatment. So the importance is that you don't lose the monitoring, you keep monitor these patients. As any hypertensive patient is on any hypertensive patient, a diabetic patient who is on treatment, and you do periodic checking for the disease status. Same is here, that we check for the antiviral treatment efficacy, for the antiviral treatment safety, and for the liver disease status. So I hope I have fulfilled my aim, which I wanted to share with you, that how we should monitor these patients on treatment. Inshallah, in the coming video, we shall be discussing that how we define the response and what is the expected response and how we go about that. Till then, Khudafis, thank you very much.